I mean, when it comes to these guys who have difficult anatomies, I mean, probably the first the first thing I want to disclose, and probably one very important thing is like, you know that in Spanish we have a saying like "nadie nace sabiendo," or "no
Yeah.
one was born knowing everything." I mean, so just yesterday I saw a quote that I wish to share with everybody here today. It's like all great surgeons were once new surgeons. We all learn from others' experiences and research and mentorship. And when in doubt, I mean, I just ask for help, seek advice from your mentors to set yourself up for success. I mean, if you do not feel comfortable doing a specific procedure, or you do not know how to do something, refer the patient to someone else. You do not need to operate on everyone. I remember when I was in fellowship, one of my mentors told me that. It's like, hey, remember, you do not need to operate on everyone. And in most cases, you have one time to make it right. So as you gain experience, you will start to feel more comfortable doing these complex procedures. And I mean, that's probably the best way to make sure that you set yourself up for success early on. And this way we will all be successful. Regarding priapism specifically, I mean, in my opinion, again, this is my personal opinion. When it comes to priapism, it's all about two things: the severity and the timing, right? If you have a patient who responds to medical therapy, it should not be that difficult to place a prosthesis. But if you have a patient who has had multiple procedures done to correct his priapism, for example, these chronic sickle cell patients who've had multiple T shunts and multiple, even proximal shunts, and they have these stuttering priapisms, those cases are going to be a little more difficult. In those cases, timing is everything, in my opinion. For example, it is not the same thing to treat a patient early on after his priapism episode, let's say weeks, versus one who had it 6 months ago or another one who had it 3 years ago. The longer it has been since his priapism episode, the more scar tissue, I mean, I will expect at the time of surgery. And specifically with ischemic priapism, it will cause, I mean, we all know it will cause extensive fibrosis inside those corporal tissues. And for these cases, you have to throw the kitchen sink at them. You need to be prepared to try multiple things in order to get a penile prosthesis in. And when you ask for pearls, I have 5 different pearls. For example, pearl number 1, education, set proper expectations. It is unlikely that the patient will have the same erection he had prior to his priapism episode. Explain that the goal is to get any prosthesis in there. You cannot guarantee that you will be able to get a fully sized implant. Sometimes the only thing you will be able to get in will be a narrow base or a CXR. And in those cases, I mean, I tell them like, hey man, there might be a possibility that I might only be able to get a narrow base implant. Once you place that narrow base, they're going to start cycling the implant. If they're not happy with that, when they start cycling that implant regularly, it will expand the tissues inside. And then when you can come back several months later and you will be able to get a bigger implant in. Pearl number 2, if you were the one who took care of the priapism or the patient was referred to you early on after his priapism episode, try to get him on your schedule as soon as possible. Remember, timing is everything. Getting an implant in sooner will be easier than waiting several months to a year later. If he had a distal shunt and he has incisions in his glands, I would wait for those incisions to heal before I get an implant in. And as soon as those incisions heal, I mean, let's say 6 to 8 weeks since usually those incisions will heal within 6 to 8 weeks. And at that time, I bring him back, for the penile prosthesis. I've had several patients who have been referred to me from local urologists who did a T-shut, for example, or they did an Algarab, or Burnett's snake procedure in which they just place a Hagar all the way down to the bone. We know that those guys are very
Yeah.
unlikely to have, natural erections again. And I tell them like, hey man, as soon as that heals, I see them, let's say, 2 or 3 weeks after their episode, they still have scar tissue. They still have their, stitches in the glands. And I tell them like, hey man, we're going to wait for this to heal and we're getting you on the schedule today. And that way, as soon as those incisions heal, we're on the schedule to get that implant in.